It's a special honor now to introduce to you Dr. Murray Sheldon. He serves as the Associate Director for Technology and Innovation at the U.S. Food and Drug Administration. Dr. Sheldon is a unique person. He is a heart surgeon. He's the former head of a company, his own company, that developed medical devices, and he serves as one of the primary regulators for medical devices at the U.S. Food and Drug Administration. But we know Dr. Sheldon in a different capacity, and that is one of the ultimate patient champions and patient advocates, not just for patients here in the U.S. that suffer from kidney disease, but patients around the world. Dr. Sheldon has been inspired through his reading and through his practice and his interaction with patients to push for a global consortium that will back efforts to deliver artificial implantable kidneys sometime in the next decade. We feel very strongly about this, that patients and regulators and doctors working together can create alternatives and bring alternatives to market in artificial organs for those patients around the world who may not have access to things like dialysis. We feel very strongly about his efforts. We're honored to have him, and he's going to talk now in a similar way that he did at our global summit because the reception to his remarks was so profound, and we're so very excited to have him again. Dr. Sheldon, go right ahead.
Today, I've been asked to speak about the global health and human suffering that will necessitate international cooperation. And this is obviously a huge problem, and I'm going to address the question of what will it take to actually get the job done. And a short answer to that question is we need to work together. We need to develop a Manhattan-type project. But the Manhattan-type project that you are familiar with is by a single country developing a bomb for war. In this case, we're talking about multiple countries developing a product for patients for world peace. And what is critical to really get this job done are partnerships. We really need to work with multiple participants in this effort. Clearly, patients are critical, but as equally important is industry, academia, nonprofits, and governments, including national governments and international governments. We really have to all work together to make this happen. And although there are many aspects of kidney disease that we are considering dealing with, including earlier diagnosis, slowing progression, and prevention, this talk is going to be focused on dialysis patients who are at end-stage renal disease and looking at how we can improve their life. And in surveys done for dialysis patients, asking them what they would like to see developed, although there are many options available, what rises to the top at 72% is next-generation renal replacement therapies, such as wearable or artificial implantable kidneys. For end-stage renal disease, we ask the question, why? Well, you, of all people, know that people on dialysis have a very poor quality of life, as well as a limited life expectancy. In fact, in this slide, looking at patients with hemodialysis, way over on the left, there are very few cancers that have a 5-year mortality worse than hemodialysis. So when you talk about somebody on hemodialysis, it's as if you're giving them a cancer diagnosis. And on top of that, it's an extremely high cost. CMS spends in excess of $34 billion per year, and as you can see on the slide, it's not flat. It's going up and it will continue to go up. But if you really want to ask the question why, it's for people. And on this slide, I have Bill Peckham, who is sitting in his raft about to go down the Colorado River. He's probably one of the best dialyzers in the world and has done it for a long time. Unfortunately, Bill Peckham, like most people on dialysis, just passed away last year, which is very unfortunate. And to the right of Bill, we see a young boy named Caleb. Caleb is 16, born with congenital disease, left him with renal failure. Caleb has been fortunate enough to have 2 kidney transplants, but unfortunate to have rejected them both and now has a slew of antibodies and is no longer a candidate. So he's on dialysis as well. Unfortunately, Caleb is running out of vascular access. He currently has no vascular access sites in his arms. And when I first met him at a Kidney Health Initiative meeting a couple of years ago in Washington, he was about to get a new vascular access in his legs. So we're focusing on treatment for these people who really, really need it. And the problem that we're really facing is we've had very little real disruptive innovation over the last 60 years. And if we think about the words from Willem Kulf, who really created dialysis, it's critical that if we're going to keep patients alive by artificial means, we incur the responsibility to see that it's a good life and an enjoyable life. And so far, unfortunately, I don't think we have created that environment yet, but that's where we need to head and make it happen. On the left side is our current gold standard, a kidney transplant. That's the best if you can get it, although very few as a percentage of patients with end-stage renal disease can get kidney transplants. In some countries, as low as 20%, other countries maybe 40%, but it's not currently available for everybody. And even then, it does require lifelong immunosuppression and medications, and rejections do occur. The current standard on the right, as you can see, between 1962 and 2020, hasn't really changed very much. The machines have gotten better, but the concepts and the approach has been the same. This isn't the same for computing technology, which has advanced miraculously over the last 50, 60 years. And you have to ask, why not for kidney patients? Obviously, there's technical challenges, but in the area of artificial organs, we have developed hearts, eyes, hips, hands, and even ears. And although we see in the end the artificial kidney, it's still basically a larger machine, bigger and fancier than the one that Koloff pictured in the slide on the left with his rotating drum developed back in 1943. And for people like Caliph, we really have to ask the question, are we trying to do too much? Is this just pie in the sky? How do we know that we can really even make an artificial kidney? Well, what has been done so far? We've actually developed portable peritoneal dialysis systems that have improved quality of life and allowed people to go to work and to travel, as well as portable hemodialysis systems. And recently, several people have developed wearable artificial kidneys that can really significantly improve quality of life, but still we're talking about dialysis. Recently, we've seen some advancements in implantable bioengineered kidneys, including cells and biofilters and bioreactors that are able to do more functions of a kidney. And there's been some great research developed into hybrid animal kidneys using their scaffold and injecting them with human stem cells and making them implantable, and xenotransplants and chimeras. And lastly, when you look at the work coming out of the regenerated kidney organs and organoids under the microscope, they really do look like kidneys. So we are making a lot of advancements. We have a lot available to make it further, but how do we really get across the finish line? How do we really get this job done? And when I think about it, and I've had the opportunity to develop multiple medical products in my career in the past, I believe it's unlikely to follow the standard pattern of most medical product development. The technology expertise needed is large, and the risks are very high for many companies. And it's going to require the use of kidney cells and biologics. And on top of this, this isn't a problem for our country alone. It's truly a worldwide problem. So we were very fortunate in a little over a year ago when President Trump issued an executive order encouraging the development of an artificial kidney and utilizing the Kidney Innovation Accelerator, KidneyX, to fund prize competitions to develop advances for kidney health. And if one studies the Manhattan Project, as I have done, this is a picture of the book written by the fellow on the slide, Leslie Groves, who was in charge of the Manhattan Project. Now it can be told, it was finally published in 1962. We learn a lot of lessons. And I'll just highlight a few things that Leslie Grove has been telling us. That it's required many individuals from many countries in many fields over many years, and a lot of issues that came up that he was unaware of, that required a real cohesive entity, and the work that they were doing were unique. But while it was unique, he felt it was very important to let other people know what they did. As they learned it the hard way, they hoped that the lessons learned would be of value to others, because he was convinced this would not be the last Manhattan Project. But it's also difficult to make predictions, as Yogi Berra has told us, especially about the future. Leslie Groves said that they had no idea the cost would run into billions of dollars, and not until later would it actually become recognized that many of the chances they took were reckless, and they continued on despite large gaps in basic knowledge, but put everything else aside just to achieve the project's single overriding aim, and that haste was essential. But of course, what else will it take? We know that answer: money, and lots of it as well. So how do we pay for this? Well, let's take a step back and think about how we paid for dialysis. Dialysis in the United States is essentially a humanitarian gift, and we have a precedent for humanitarian gifts. In 1972, the Social Security Act was amended to allow anybody, even those who are not 65, who had chronic renal disease requiring hemodialysis or a transplant, would be deemed disabled for purposes of coverage under Medicare. So essentially, who gets dialysis? In 1960, that was a big question, but not in 1972. Medicare took over the end-stage renal disease program, and everybody in the United States who needs dialysis gets dialysis paid for by the United States government. It's a good model, and I think we should continue to follow it. But how did that law get passed? And it's quite interesting if you go back in history and look at it. Shep Glazer, I believe he was one of your members of your group at AAKP, a dialysis patient, came to Congress, and he spoke about his condition. And I like to highlight that one phrase: if your kidneys fail tomorrow, wouldn't you want the opportunity to live? Wouldn't you want to see your children grow up? And Glazer was actually dialyzed briefly before the committee. And that event was widely publicized and may have been very decisive to get that law passed. But when we look at the statements from the senators and the congressmen who voted for it, Senator Russell Long stated, "These patients really need help. It's critical. And that help must come now, as many of them, without assistance, simply will not be alive for another 2 years." The same is true today. And Senator Vance Hartke actually stated that now we have this opportunity, and he proposed that we take that opportunity now before more lives are lost needlessly. The Senate, after 30 minutes of floor debate, passed the resolution 52-3. So this is my vision: the development of an artificial kidney created by an international consortium and provided to people around the world free as a worldwide humanitarian effort for peace. Multiple nations around the world will be contributing scientific and bioengineering expertise as well as financial support for people like Bill Peckham or Caleb who have end-stage kidney disease who cannot get a transplant. And these should be built in advanced manufacturing centers around the world and distributed in some way, such as the World Health Organization or something else, for everybody who needs one. Can we do this? Well, let's think about what we have already. Although I haven't gone into it much in this discussion, many of you are aware of the Kidney Health Initiative roadmap that actually draws out how we can get from here to there. And KidneyX has already gone through 2 phases of redesigned dialysis competitions, as well as a Patient Innovator Prize competition, and we'll be launching later on this year the Artificial Kidney Prize. But key is patient participation. And that's why I'm talking to you, and that's why we're working together with you, because we really need to work together to make this happen. It won't happen any other way. So, an international Manhattan Project, but for peace. The development of an international consortium for development of an implantable artificial kidney. And why is this so important? Well, if you look at the numbers on the left, in 2000, most of the dialysis was centered in the United States, in Europe, and in Japan, with only 34% in other places. But by 2013, other areas around the world have exceeded that, doubled to 56%. And it's not because that's been reduced in the United States. It's because that the prevalence is increasing in emerging economies with increasing incidence of diabetes and hypertension, the standard underlying causes of many cases of end-stage renal disease. But we believe that by including expertise and financial support from countries around the world, that all countries can lend some support, and then we'll have access to an artificial kidney for their patients. We want to bundle the best minds and resources from all over the world to be part of the roadmap and KidneyX. And CKD, while sitting now in 2016 as the 16th leading cause of early death, is postulated to rise to number 5 above all cancers. And by 2013, the International Society of Nephrology has estimated that 14.5 million people will have this, and yet only a third will be treated, and that 2 million people will die each year with little or no access to either hemodialysis or kidney transplant. But we have another roadmap to follow. It's a great example, the International Space Station, put together by 16 countries, multiple organizations with launch sites in multiple places around the world. So how was the International Space Station stood up and organized? This was done by President Ronald Reagan, who in 1984 gave a speech to propose a permanently manned space station, but he explicitly stated that the United States would invite other nations to join in the project, and spelled out the benefits to be derived from such a space station, and said specifically that NASA will invite other countries to participate. So we will strengthen peace, build prosperity, and expand freedom for all who share our goals. And I hope that President Trump this year will expand on his executive order to organize and announce the development of an international consortium to create an artificial implantable kidney. Just recently, we've had publication out of Brazil from Bernardo Cabral and others about a survey that he completed asking renal replacement therapy experts from more than 100 countries around the world, utilizing the approaches developed in the roadmap, as you can see, biohybrid, enhanced dialysis, portable, wearable, or regenerated kidney, about what they thought would most likely be developed over the next 10 to 20 years. And the winner, at least in their judgment, was a biohybrid implantable kidney, followed up very closely by portable and wearable devices. And on the right-hand side, he also asked them what they thought which one of these technologies would be most likely to mimic 5 particular kidney functions. And while regenerated kidneys would probably do the best. We kind of think that we're not quite ready for that yet, but along the way, I think that we will follow a progression of developing portable, which we already have, some wearables that we already have, miniaturize them, make them implantable, and eventually regenerate our kidneys. So this is my vision of the future and how that international consortium might be thinking. And the American Association of Kidney Patients is well involved with helping us and developing international collaboration. I was very impressed in 2019 when the Global Summit was first initiated and the work that they've done. And I understand that this year that the AAKP has proposed to endorse an international consortium at your meeting this year. The leadership has made a commitment to demand a change in the status quo and to demand newer solutions. They did that in 2019, and this year hopefully will make it happen through an international consortium. And kidney patients are the best, really, because there was a flash survey that is currently still underway, and we hope will be completed by the time you see this recording in the next day or two, that as an individual who suffers from kidney disease, we're asked if their insights would be shared to help other fellow patients, and even those who are yet to be diagnosed. 93% of you said yes. Thank you. You're the people that I'm trying to work for and work together. So to end towards where we began, if we want to go fast, this is an old African proverb. If we want to go fast, we go alone. But if we want to go far, we go together. And we definitely want to go far into the world of disruptive technology. And we don't necessarily want to build a better dialysis machine. We need to go together worldwide to really make a change for Caleb, for Bill Peckham, and for all of you listening in the audience. So I really thank you for the opportunity to present this information, and I'm certain we'll have some questions and an opportunity to further discuss this. Thank you very much for this opportunity.
Thank you very much, Dr. Sheldon. And for those who just watched these comments by Dr. Sheldon of the FDA, you'll be seeing much more about a global push and collaboration for artificial implantable organs. We will encourage you to be part of that dialogue and to support the efforts of FDA, medical professionals, and researchers and patient organizations globally. Count on us. AAKP will give you plenty of opportunities to be involved. Thanks again, Dr. Sheldon.